Okay, so let's talk about Meniere disease. Very ambiguous or very mysterious disease, Meniere disease. It is very correlated with endolymph hydrops, namely, we are getting too much, for some reason, too much endolymph. There are speculation and theories why it happens, but the bottom line is that we are getting too much endolymph. The endolymph is in the cochlea and in the labyrinth in the vestibular area, and in the cochlea you can, if you look closely on the cochlea, let's take a cross section, you will see some parts, but in the middle part there is the scala media. There in the scala media the endolymph is endolymph, and here the perilymph, and here again the perilymph. This is the scala tympani and scala vestibuli. Now here the endolymph in Meniere disease is just starting to get too much. I mean, it's starting, or overcreation. There is here vascular component that can create stria vascularis, that can create endolymph. So this stria vascularis may be creating too much of the endolymph, or where the endolymph should get absorbed, or at least uh, at least to protect the cochlea from too much endolymph, there is the endolymphatic sac. This endolymphatic sac should get and remove the excess endolymph. There may be a problem with collecting the endolymph. Anyway, the areas in which the endolymph is accumulated is all around the cochlea, but the most problematic part is this one. It is here. It is in the apex. If we are talking about the cochlea, there is the base of the cochlea and there is the apex of the cochlea. As we are getting toward the apex, the cochlea becomes less stiff. The base is stiff and the apex stiff. I don't know how do you say stiff. And the apex is much less stiffer. So because the apex is much less stiffer, here in the apex usually the damage starts. And in the apex, if you remember, there are the low frequencies. Therefore, what we see is damage to the lower frequencies in Meniere disease. Now, what is damaged are the hair cells. The hair cells are damaged. And because of this combination of damage to the hair cells and low frequency damage, what we see in Meniere disease is an audiogram that looks like this. It can be like this, for example. And this is air and bone conduction. Namely, we see sensory neural hearing loss because damaging to the hair cells cause sensory neural hearing loss, and it's in the lower frequencies. Here is the higher frequency. There can in the start be okay, but the lower frequencies are damaged and the thresholds are higher. So in Meniere disease there is an accumulation of endolymph, and the damage is especially for the apex where the scala media is more pronounced and the apex is less stiff than the base, So the damage to the hair cells starts in the apex of the cochlea where the low frequencies are processed. Therefore, in Meniere disease, especially in the start of Meniere disease, we see hearing loss in the low frequencies. So, Meniere disease, as you understand, can cause hearing loss, low frequency sensory neural hearing loss. But there are other problems that this endolymph hydrops, accumulation of endolymph, can cause. It can cause vertigo, and this is more related to the labyrinth, where it can cause vertigo. It can cause hearing loss, as we just discussed. It can cause oral fullness. They're feeling like pressure inside the ears. It can cause tinnitus. So, hearing loss in the low frequencies. This combination is very characteristic of Meniere's disease, even though many other diseases can cause vertigo, dizziness, tinnitus, hearing loss, but the low frequency hearing loss, which is sensory neural with vertigo and tinnitus, and which is episodic, very important in Meniere. Those are episodes of vertigo, hearing loss, oral fullness, and tinnitus. Usually, each attack of Meniere disease lasts around between of vertigo. It starts like an attack. Sometimes they even know that an attack is going to come. It lasts anywhere between 20 minutes to 24 hours of vertigo. And in those attacks, the patients experience can be severe vertigo, hearing loss, oral fullness, and tinnitus. After the attack passes, the patient can get into remission until the next attack comes and can vary in time frame, even after 1 year another attack. But as the disease progresses, the hearing loss becomes more and more constant. Therefore, even between attacks of Meniere, still the patient will have hearing loss, especially sensory neural hearing loss in the lower frequencies, but as the disease progresses, it can get worse and in other frequencies. But the interesting part is that there are not very good diagnostic tools. We can do an audiogram to look for the low frequency hearing loss, which is sensory neural, which is not very common. As you know, sensory neural hearing loss is usually on the higher frequencies, and conductive hearing loss is on the lower frequencies. But here we get sensory neural hearing loss, which is in the lower frequencies, which is quite helping in understanding that maybe the patient has Meniere's disease. Maybe. So audiogram can help. Tympanometry can't help too much because tympanometry tests for the middle ear, but we have a problem in the inner ear, no the middle ear. So tympanometry is not a really good tool for this. It can help us. What do I mean by not a good tool? It can help us rule out other causes. I don't know, middle ear effusion, even though it should be conductive hearing loss, and so forth and so on. But it won't help us diagnose Meniere disease because it should be okay. Now, the audiogram, as we talked, we can use the echocochleography, which may show SP to AP ratio, which is elevated, usually between more than 0.5. It is elevated. Aside from this, what we can also use is the clinical presentation is the most important. Again, episodic hearing loss, tinnitus, vertigo, and oral fullness with fluctuating hearing loss. This is the most characteristic presentation of Meniere's disease. Now, what is the treatment? What is the treatment for Meniere disease? The treatment is quite problematic. the treatment is quite problematic. Remember that it is a chronic disease, and as the disease progresses, it becomes more severe and more debilitating. Now, the treatment can be for acute attack, and for acute attack, we have antihistamines, H1 blockers, let's call them. We have benzodiazepines. We have sometimes steroids, and for preventing, we have diuretics that I must say that their role and their efficacy in treating Meniere's disease is quite controversial. Now, the idea of diuretics is that we reduce the amount of fluids in the body, and as you remember, Meniere's disease is based on endolymph hydrops, so we want to reduce the amount of endolymph. Yet, I'm not sure it's really working. It's not very evidence based, but it is given. Now, there are other diseases. There is sac decompression. As you remember, as we talked, there is the endolymphatic sac that should absorb the endolymph, so you can decompress this sac with a shunt in order to try to decompress and reduce the amount of endolymph. It can work. Endolymph sac decompression. Another treatment is gentamicin. Gentamicin injection or intratympanic injection. As you remember, aminoglycoside, including gentamicin, are ototoxic drugs, so we can try to damage the inner ear in order to abolish the vertigo and everything, maybe the vertigo. So we're essentially damaging our labyrinths in order to reduce how it works, reduce its function, so it won't cause vertigo. There is also an invasive procedure which tries to cut the vestibular part of the 8th cranial nerve, the vestibulocochlear nerve, in order to reduce the vertigo of Meniere disease. Again, we are destroying something in order to reduce the symptoms of Meniere's disease. Those are the main treatments. So for acute attack, antihistamines, benzodiazepines, steroids, and for treating chronically, diuretics, sac decompression, gentamicin, and cutting the vestibular nerve. Now, remember that not all the treatments are really proven to be efficacy. For example, the diuretics are very mainstream and let's call it first line treatment, but the evidence is quite low. And that's it. That's what I wanted to talk about. Some words about Meniere disease. I'm sorry if I forgot something or made any mistake. Correct me if I'm wrong in something. Thank you very much. This was about Meniere disease, and that's it. The etiology. The etiology is not, maybe I'll talk about it in a minute. The etiology is not really known. Let's call it unknown, even though Meniere disease is known for more than 100 years. The pathology that can be seen again that it is endolymph hydrops, but why the endolymph is becoming oversaturated is not really known. It may be viral, it may be autoimmune, it may be genetic. It's not really known. The etiology is not known, but we know that there is endolymph hydrops. Thank you very much. If there are any mistakes or correction, please tell me, and that's about Meniere's disease.